Welcome to this clinical presentation titled The Weight of a Cough, a Diagnostic Chase. As you can see on this opening slide, we are tracking the case of an elderly woman who presents with subacute constitutional symptoms, a persistent cough, and an abnormal chest x ray. The case involves a hybrid clinical team of human and large language models, where user Dr. Anupam inputs case details to large language models Gemini, Grok, and GPT 5.4, which are in roles of resident, attending, and expert, respectively, mimicking real life grand rounds. This case is particularly interesting because the diagnosis evolves significantly as new data emerges. We will follow the reasoning path from a primary care perspective all the way to a complex malignant pathology. Along the way, we will observe how bedside priorities shift with each new piece of information provided by our clinical team and various consultants. Looking at the text in the center, our goal is to understand the diagnostic evolution from simple symptoms to a complex underlying disease. Before we dive into the specific patient details, let us take a moment to establish our core learning objectives for this session. Looking at these learning objectives, we have divided our focus into clinical reasoning and management priorities. In the left column, we aim to recognize the diagnostic pivots that occur when an exudative pleural effusion is discovered in a patient with significant weight loss. We also want to understand how unexpected cellular differentials can disrupt standard workups and learn how to differentiate early anchoring from a structured reevaluation. On the right side, our management goals include prioritizing immediate bedside interventions like ultrasound guided thoracentesis and identifying red flags in fluid cytology that demand deeper immunophenotypic evaluation. Finally, we must learn to balance diagnostic momentum with patient safety and avoid unnecessary radiation exposure. These objectives will guide our journey through the patient's diagnostic timeline. Let us move forward to see how this discussion will be structured across different stages and perspectives. This slide outlines our session format, which is designed to mirror a real-world clinical consultation. On the left, you can see the 4 stages of the case, starting with the initial presentation and imaging, moving through fluid sampling, advanced pathology, and finally confirmatory tests. On the right, we highlight the different perspectives that will weigh in. The doctor reveals the objective clinical data, while the resident offers a first-pass interpretation. The consultant then critiques the safety and sequence of events, and the expert synthesizes the data into the most probable syndrome. This multi-layered approach helps us see how different levels of experience interpret the same set of facts. This collaborative framework ensures we examine the case from every possible angle. Now that we have the roadmap, let us examine the initial clinical presentation of our patient. As we look at the initial presentation, we have a 79-year-old woman presenting with a 4-week dry cough and fatigue. Notice the significant 10.4 kilogram weight loss over the past year. Her history includes travel to Southeast Asia 3 months ago and a family history of maternal lymphoma. Examining the section on the right, her vitals are stable, but she has diminished breath sounds and dullness at the right base, while her blood counts and kidney function are normal. Her total protein is 8.0 grams per deciliter, and her inflammatory markers are elevated. The chest X-ray confirms a moderate right pleural effusion with airspace opacities in the middle and lower lobes. These findings suggest a process that is more than just a lingering infection. With these initial details in mind, let us pause to consider the most likely diagnostic framework. In this audience pause, we are faced with a critical question: what should dominate the diagnostic frame right now? Looking at the options in the blue boxes, we must decide if this is an unresolved infection like tuberculosis driven by her travel history, or perhaps an occult malignancy. We also need to consider how that 10.4 kilogram weight loss reframes a relatively short 4-week cough. Is the cough a new symptom of an old problem, or are they unrelated? Finally, we must determine the single most important next step to take at the bedside to gain more clarity. In an elderly patient with these specific findings, the clinical pressure to find an answer is high. Let us see how our resident consultant and expert interpret these initial clues to narrow down the possibilities. Looking at the reasoning at stage 1, we see 3 distinct viewpoints. The resident in the first column suspects a post-infectious or paraneoplastic effusion and considers drug toxicity or a lung primary. In the middle column, The consultant warns against early anchoring on drug toxicity and emphasizes that weight loss plus an effusion in a 79-year-old is malignant until proven otherwise. They strongly urge an ultrasound guided thoracentesis. The expert in the right hand column defines the core syndrome as a subacute cough, unilateral effusion, and major weight loss, while tuberculosis remains a top alternative. The expert identifies the imaging confirmed effusion as the pivot that mandates immediate fluid sampling. This consensus on the need for a TAP highlights our first major teaching point. Let us explore the clinical pearl associated with this stage of the workup. This teaching pearl focuses on the critical bedside action required for this patient. As shown in the brown box on the left, the constitutional burden is out of proportion to a simple upper respiratory infection. A 10.4 kilogram weight loss fundamentally changes the differential from a lingering cough to a systemic or malignant process. On the right, the blue box outlines the diagnostic mandate. In an older patient, a unilateral pleural effusion combined with profound weight loss is a diagnosis to tap, not to temporize. This means that a diagnostic thoracentesis is the inescapable next step to move the case forward. We cannot rely on imaging or history alone when the stakes are this high for a potential malignancy. Now, let us look at the results of that pleural fluid analysis and the subsequent imaging. Stage 2 brings us the pleural fluid results and more detailed imaging. As you can see in the left column, the thoracentesis yielded 1.3 liters of yellow turbid fluid. The protein of 5.6 grams per deciliter and LDH of 230 units per liter confirm this is an exudate. Most strikingly, the differential shows 54% unclassified cells, which is a major red flag. On the right, the chest CT imaging reveals a moderate to large right pleural effusion and complete consolidation of the right middle lobe due to mucus plugging of the bronchus. This combination of an exudative effusion and an obstructed airway significantly narrows our diagnostic path. The presence of so many unclassified cells suggests we are dealing with something quite unusual. Let us pause again to think about how these new findings change our clinical probabilities. During this second audience pause, we need to interpret these unclassified findings. Looking at the questions on the screen, we must ask what an exudate with 54% unclassified cells strongly implies. Usually, such a high percentage of cells that the lab cannot easily identify points toward a hematologic or rare malignant process. We also need to consider how the finding of mucus plugging and lobar consolidation changes our anatomical frame. That cells. Does this point toward a primary lung cancer obstructing the airway or something else? Finally, we must decide what specific follow-up testing is immediately required for the pleural fluid to identify those mysterious cells. This is a pivotal moment where the focus shifts from the lung parenchyma to the cellular level. Let us see how our reasoning team handles this shift. At stage 2, the reasoning shifts from a general effusion to a specific endobronchial obstruction. The resident now pivots toward a malignant pleural effusion from a lung primary, flagging the 54% unclassified cells as a massive red flag. The consultant in the middle critiques the order of operations, noting that the CT was ordered before the fluid was fully interpreted. They also warned that tuberculosis with endobronchial involvement remains a dangerous alternative that must be excluded. The expert synthesizes all this data into a single problem, an obstructing endobronchial tumor. They emphasize that the unclassified cells demand urgent immunophenotyping to determine their origin. This focus on both the anatomy and the cells leads us to our next major teaching pearl. Let us look at the red flags we have identified so far. This slide highlights the anatomical and cellular red flags that should guide our thinking. On the left, the green box explains the anatomical clue. A unilateral exudative effusion plus lobar collapse from mucus plugging is an endobronchial tumor until proven otherwise. This is a classic presentation that requires direct visualization or biopsy. On the right, the blue box addresses the cellular clue. Those unclassified cells, which make up over half the differential, must be treated as malignant until formal cytopathology and flow cytometry prove otherwise. We cannot ignore such a high percentage of abnormal cells in an exudate. The next step is to get a definitive identification of these cells to see if they match our suspicion of a lung primary. Let us move to the cytopathology and staging results. In stage 3, the cells are finally identified, and the results are surprising. As you can see in the blue box on the left, the cytopathology identifies the unclassified cells as numerous mature appearing plasma cells, including atypical forms with nucleoli and binucleation. This is a major departure from the expected lung carcinoma. On the right, the staging imaging adds another layer of complexity. The PET CT scan shows intense uptake not only in the right middle lobe consolidation but also in a hypermetabolic mass in the left maxillary sinus. A biopsy of this sinus mass was performed to see if it matches the lung findings. We are no longer looking at a simple lung tumor, but a multifocal process involving plasma cells. Let us pause to consider the implications of this dramatic turn. This third audience pause asks us to rethink everything. How does the identification of plasma cells change the differentials? We must ask if this confirms multiple myeloma or if there are other plasma cell disorders, such as extramedullary plasmacytoma, to consider. Looking at the second bullet point, we need to figure out how the sinus mass ties in with the pleural findings. Is this a systemic disease that has spread to these specific locations? Finally, we must identify which specific serum and marrow tests are now mandatory to complete the workup. The shift from a suspected lung primary to a hematologic process is a classic example of how pathology can completely reframe a case. Let us see how the clinical team adjusts their reasoning to this new reality. In stage 3, hematologic malignancy takes center stage. The resident correctly shifts their focus to extramedullary plasmacytoma or myeloma, linking the lung and sinus disease as systemic spread. They also note the surprising lack of anemia or renal failure, which are typical for myeloma. The consultant, however, warns against premature anchoring and suggests that reactive plasmacytosis from an infection is still a remote possibility. They also point out a staging error, noting that the PET CT was done before basic serum electrophoresis. The expert identifies the cell identity change as the true pivot. They note that a second extranodal mass in the sinus is classic for extramedullary plasma cell disease. This leads us to a crucial lesson about when to abandon our initial hypotheses. Let us look at the next teaching pearl. This teaching pearl emphasizes the power of cytopathology in diagnostic reasoning. In the green box on the left, we see that the case pivoted completely on cell identity. What originally looked like a primary lung obstruction is now clearly part of a systemic hematologic process. On the right, the blue box highlights the significance of atypical plasma cells. Finding these cells in pleural fluid is a diagnosis-changing clue. It forces us to think about myelomatous or extramedullary plasma cell neoplasms rather than standard lung cancer. This realization reminds us that while imaging provides the map, pathology provides the destination. We must now look at the specific immunophenotyping and bone marrow results to nail down the exact type of plasma cell disorder. Let us examine those final laboratory details. Stage 4 brings us to the immunophenotyping and bone marrow results. Looking at the blue box on the left, flow cytometry of the pleural fluid shows that the plasma cells express marked IgM and are positive for CD45 and CD19 with severe lambda light chain restriction. This monotypic IgM lambda profile is also confirmed by a serum protein electrophoresis M spike. On the right, the bone marrow biopsy shows less than 5% plasma cells, which effectively rules out overt multiple myeloma or typical Waldenstrom macroglobulinemia. Furthermore, PCR testing for the MYD88 mutation is negative. These specific markers and the empty marrow point toward a very rare diagnosis. We have all the pieces of the puzzle now, but they do not fit the common patterns. Let us look at the final diagnostic challenge. In this final audience pause, we face the ultimate diagnostic puzzle. What is the diagnosis when IgM is produced outside the marrow? Looking at the bullet points, we need to explain why an IgM M spike makes true multiple myeloma unlikely, as myeloma is typically IgG or IgA. We also need to understand how a negative MYD88 and a clear marrow rule out classic Waldenstrom macroglobulinemia. Finally, we must consider the most dangerous complication to monitor for in an elderly patient with a significant IgM spike. IgM is a large molecule, and high levels can lead to serious vascular issues. This case has moved from a common cough to a very rare hematologic presentation. Let us see how the expert team synthesizes these final complex details into a definitive diagnosis. The reasoning at stage 4 focuses on defining this rare extramedullary neoplasm. The resident concludes this is likely an extramedullary plasmacytoma with IgM secretion or perhaps a marginal zone lymphoma, prioritizing testing for hyperviscosity. The consultant agrees but demands sinus tissue immunohistochemistry to confirm monoclonality before final anchoring. They also remind us not to completely drop the possibility of infection until the tissue is confirmed. The expert in the right column synthesizes the phenotype, monotypic IgM lambda cells located largely outside the marrow. This moves the diagnosis away from classic myeloma and Waldenstrom toward a rare extramedullary IgM plasmacytoma or a lymphoplasmacytic lymphoma. The final answer rests on the sinus histology. This brings us to our final teaching, Pearl, regarding how phenotype drives diagnosis. Our final teaching, Pearl, emphasizes that cell phenotype is the ultimate guide to diagnosis. As you can see in the green box, it was the specific identity of the cells, IgM producing, lambda restricted, and CD19 positive, that ruled out the common hematologic suspects. These details are essential for distinguishing between similar looking disorders. On the right, the blue box gives us a clear rule of thumb. When an IgM monoclonal plasma cell process is extranodal, with little marrow involvement and negative EM-YD8, you must think of extramedullary plasmacytoma or marginal zone lymphoma before Waldenstrom. This case serves as a powerful reminder that rare presentations of plasma cell disorders can mimic common pulmonary issues. Let us now review the full diagnostic timeline to see how this case evolved from start to finish. This diagnostic timeline provides a clear summary of how the case evolved through 4 distinct stages. In stage 1, a subacute cough and weight loss made malignancy the primary suspect. By stage 2, the focus shifted to an obstructing lung carcinoma due to the CT findings and the unclassified cells in the fluid. Stage 3 brought an abrupt shift to an extramedullary hematologic process after cytopathology identified atypical plasma cells and PET imaging found a sinus mass. Finally, in stage 4, immunophenotyping and a clear bone marrow pointed to a rare extramedullary plasmacytic neoplasm. This journey highlights how clinical reasoning must remain flexible as objective data challenges our initial assumptions. We started with a cough and ended with a rare hematologic disease. Let us conclude with a final synthesis of the key takeaways. Our cattle is adapt to bed synthesis. In our final synthesis, we reflect on a 79-year-old woman whose presentation of weight loss and pleural effusion initially mimicked a primary bronchogenic carcinoma. The discovery of a lobar obstruction on CT and unclassified cells in the fluid initially supported this lung-centric view. However, detailed cytopathology and immunophenotyping correctly identified a rare extramedullary monotypic IgM lambda plasma cell process that matched her sinus mass. This case highlights the vital importance of pursuing an objective cellular diagnosis rather than anchoring on initial imaging patterns. It also reminds us to rigorously check for end organ risks such as hyperviscosity when an IgM spike is discovered. Always remember to look beyond the obvious anatomical findings to the underlying cellular identity. Ask for the TAP, screen for atypical cells, and provide a diagnosis based on objective evidence.